So this morning, 400,000 Americans woke up with medically refractory epilepsy. Let that sink in. No? And that means for 400,000 Americans, they're left with the very difficult options regarding the rest of their care. And so one of the things that we're very focused on at MindTrace is making sure that these patients have understanding of the options before them. And one of those options is surgical intervention. Now, surgical intervention comes with its own risks. In particular, there are key cognitive abilities that patients need to understand that could potentially be damaged by going forward with the surgical intervention, right? So we're talking language, we're talking memory, everything that we bundle into cognition. And so at MindTrace, we're really set on developing the next generation of neurosurgical planning tools that can start to understand and quantify the trade-offs that decisions have to be made when understanding whether or not to pursue with surgical intervention. So these are some of the patients that we've had the good fortune of being able to work with during early development of our technology. And really what it comes down to is MindTrace tries to keep people who they are, right? There's an inherent balance that is trying to be struck for these patients when they're having seizures and trying to understand what the road ahead looks like. And so for these patients in particular, really making sure that you can begin to quantify the trade-off and bring new evidence to this decision-making process is something that we are very much involved with at MindTrace right now. So where we come into the picture with clinicians, all of you are collecting incredible amounts of data to try to protect the person. Right. And so where we really fit into this picture is by aggregating and fusing together all of that incredibly rich neuroimaging and behavioral data that you're collecting as part of standard of care. We're able to compile this in new ways to help facilitate the clinical decision-making process. MindTrace is a software as a medical device that is really intended to facilitate the clinical decision-making process. Because at the end of the day, what you're all trying to do, right, is protect outcome while also removing the seizures, but also making sure that these people remain who they are following these surgical interventions. And so really where MindTrace fits into this portfolio, if you will, is by being able to close the loop and allow you to take your past patients and the learnings that you got from them and apply those to your future patients. And we do this by leveraging machine learning and artificial intelligence. So just to give you a sense of how we got here, we spun out of Carnegie Mellon 2 years ago. We've been very fortunate in that in our DNA was customer and user discovery. We had the opportunity to travel the country to 25 different medical centers and really evaluate and understand through conversations with clinical teams where are the gaps in managing these very complex epilepsy cases right now. That allowed us to move forward. We did our tech transfer agreement with Carnegie Mellon University. We've also been through a handful of healthcare accelerator programs. Our philosophy has been, it takes a village to build a company. It takes many villages to build a healthcare company. That's also allowed us to get an IRB approved, an umbrella IRB. And we just had our FDA Q-Sub meeting a few weeks ago where they've clarified for us what the regulatory path forward really looks like. So for us, the next step, the tangible next step is a breakthrough device designation application to the FDA. We also just opened up our pre-seed round a couple of weeks ago, and I'm happy to report that we've already got about a quarter of that round soft circled in Pittsburgh with the 2 primary life science investor groups in Pittsburgh. And really what that pre-seed round is meant to do is to put in place a team that can be in place and responsive as we begin deploying early versions of the software system at 7 high volume centers here in the US. So just a little bit about our team. My name is Max Sims. I'm one of the co-founders and CEO. I've always been very interested in having one foot in science world and one foot in business world. And that motivated me to go out and get one of the country's first STEM designated MBAs. I had the good fortune to get to know Dr. Mahon and Hugo over the course of the last 4 or 5 years. Dr. Mahon, who'll be joining me during the Q&A, did his PhD at Harvard. He's tenured faculty at CMU with over 75 publications in this space and just started his sabbatical 3 days ago to be joining MindTrace full-time for the foreseeable future. Hugo also graduated from CMU's computer science master's program, arguably one of the top in the world, has really been leading our software engineering team. I mentioned it takes a village, and it takes many villages in the case of this kind of company. So we've been very fortunate to get help from business advisors and medical advisors who can help us identify where the landmines are and make sure that we're not going to be able to step on those. So particular thanks to Frank Fisher, who I know is in the audience today. So with that, I will pause there. We're looking forward to your questions and invite Brad to join me up here.
A question for you about machine learning. Fundamentally, what machine learning does in many cases is it's sorting, right? So my favorite sorting algorithm is probably the sorting hat from Harry Potter. And in that case, the question of what is determining is very clear. In this case, when you are applying machine learning in this environment, what is the question that you are answering with machine learning, and how are you segregating data sets, and how is that clinically useful?
No, thank you. It's a great question. I think really when it comes down to with this particular application in terms of surgical management of epilepsy is risk stratification of tissue. There's the question of localizing the seizures, and then there's the question of whether or not that epileptogenic focus can be safely removed and let that person get back into their life. So our AI and ML is specifically focused on the localization of function, which may be an atypically organized brain in individuals to allow them to take out that seizure focus and protect that person. Interesting.
Yeah. Great presentation. Just follow-up question about that. What information are you using to determine the cognitive map for an individual patient?
Great question. So our approach is to build a software as a medical device platform that fits like an invisible glove over the existing process. So what that means is that we need to interface with all of the standard of care measurements that are currently being collected. That includes everything that's currently in the electronic medical record for that patient. It includes all of the medical imaging, and for instance, in PACS. And it also includes some centers do assessments of patients that are not reimbursed and are standard of care for that center, but may not be standard of care for every center. And so we really are taking a very wide funnel. So for instance, functional MRI may be a very valuable technique for localizing function that one center may use, but another may not use. And so we're really developing our technology to be able to take advantage of all of that data and bring it into one common space for that patient.
Just a follow-up question. So how is this different than the other commercially available and used software platforms that I think most of us use in our surgical programs like BrainLab or ROSA?
Yeah, so we actually have designed our platform to be interoperable with BrainLab and with ROSA and with Medtronic, because ultimately we don't want to compete with them in terms of what they're doing. What they're very good at is they're very good at showing the anatomical organization of the brain and registering that to the patient in a clinical context. I would describe the existing status quo as analogous to 20 years ago. If you were driving to San Francisco, you'd use a road atlas and it would show you where all the roads are. And that's kind of what we have right now. We have incredible depth of invasive and non-invasive imaging to map the human brain. But now when you want to go to San Francisco, you put your destination in Google Maps and it gives you the travel time. That's what MindTrace is trying to do, is to give the travel time for a given approach in a particular intervention.
So listen, I think it's a good idea, and it's something we face every day when we're looking at patients. We're trying to work up patients for epilepsy surgery. I'm interested in general how you take the approach, because you have a lot of tests that simply said, give us, I would say, false positive data. All right. So let's say like functional imaging tends to overestimate functional areas to much bigger than what we might know from more traditional things like electrocorticography. Or I think also I saw you integrate neuropsychological data in, which again, I think probably can be something that overestimates deficits and we don't have any perfect test. So it seems to me the hard part is that since we don't have the perfect test for epilepsy, how would you go out looking at these things that call false positives? And if you can summarize that idea, how you'd go at it in the big picture.
It's a great question. And really the answer to that question drives our technology development and our focus over the next 18 months. We're specifically focused in this space of surgical management because it provides two kinds of causal evidence that are critical for the development of our algorithms. One of that is reversible stimulation, right? Electrical stimulation that's used in these patients to map function. And what's important about that kind of evidence is that when a particular region of the brain is stimulated and the patient becomes unable to, for instance, name a picture, that is ground truth exactly to be able to calculate false positives, for instance, on a prior functional imaging study that may or may not have shown that region to be active. The second kind of causal evidence is post-operative neuropsychological performance as a function of the volume of resection. And again, this is the key data point for us because we've seen in our own hands many times surgeons resect regions of the brain that showed up, for instance, on fMRI as being active, and yet the patient does not have the postoperative impairment that you might think they should have if you simply read the fMRI scan. And that is exactly the gap that we can close if we can track patients longitudinally across doctors, across centers, and over time to be able to take that outcome data and use it to reinterpret all of the information that was available at the time of the original decision.
One more question for me. So with all of the heterogeneity in the surgical population, how many patients do you think you need this really enriched data set of preoperative multimodal data, potentially electrophysiology data, and like robust neuropsychological data pre and post surgery to really make this work where it's reliable to the point where we're not denying surgery to some patients because your algorithm says that it might be dangerous?
Yeah, that's a great question. I'm going to answer it very succinctly. The way that we've thought about doing this is to focus initially on high frequent areas of intervention. Okay. Temporal lobe epilepsy represents an area that has very stereotyped impairments associated with resective surgery in terms of verbal memory and in terms of naming performance. And so we really want to develop our algorithms within a rather narrow space where not just us, but the broader scientific community has made incredible progress in understanding what the factors are that wind up predicting outcome. So we want to not try to predict outcomes for the whole brain. We want to start with some well understood systems. And this very much dovetails actually with our regulatory pathway, which has now been validated based on the written feedback from the FDA, where we specifically defined effectiveness for our device initially as being able to make better predictions of patient outcome based on all of this information. So that's stage one. We anticipate, as a direct answer to your question, that probably about 100 patients will get us to that place. That's based on power analyses that, again, come out of the scientific literature. And for the 7 centers that we're initially targeting, we're looking to do very focused initial feasibility studies where we recruit between 15 and 20 patients per year at each center. So the plan is that over 12 months, we will get to a data set that will be a closed historical data set that we'll be able to use at FDA to demonstrate better prediction. And then the next phase that we haven't talked about yet would be actually to demonstrate better outcome. And when you demonstrate better outcome, then we're well aware that we're going to need to recruit many more patients. And we're also well aware that we're going to have to take this company to the next level to do that. And so that's what we're looking forward to do.
All right. Thank you, Brad. Thank you, Max.